Now I'm going to discuss about important group of adrenal disorders in children, which include Cushing syndrome, adrenal insufficiency, and congenital adrenal hyperplasia. First, I'm going to discuss about Cushing syndrome. We all know Cushing syndrome is a condition of increased glucocorticoids in the body. And what could be the reason for this glucocorticoid or the etiology of Cushing syndrome? It could be either an endogenous cause or an exogenous cause. Exogenous means something which is from outside the body. Endogenous means something which is produced inside the body. Overall, exogenous causes are more common compared to the endogenous cause. And in that exogenous cause, it is due to prolonged intake of steroids. It could be due to treatment for medical conditions like autoimmune disorders or chronic inflammatory disorders where the child needs to take steroids for a long duration. That is the usual reason for Cushing syndrome in children. The other variety is endogenous. Endogenous is due to increased production from the adrenal gland, and this can occur under the influence of ACTH or without the influence of ACTH. So, in the endogenous variety, the two common categories are ACTH dependent and ACTH independent. In ACTH dependent, there will be increased levels of ACTH. And depending on the source, we can classify further. What is the usual source of ACTH? It is the pituitary. And it is noted in conditions of pituitary adenoma, wherein the pituitary produces excess of ACTH. This ACTH would cause stimulation of the adrenal gland to produce a lot of glucocorticoids. And if pituitary adenoma is the cause of Cushing syndrome, we call that condition as Cushing's disease. So pituitary adenoma is called as Cushing's disease. The other source of ACTH could be an ectopic source. That means a source other than the pituitary. And what is that ectopic source? In children, it is usually a tumor. The usual tumor is neuroblastoma. That is the most common tumor which is characterized by ectopic production of ACTH. The other tumors include Wilms tumor and rarely carcinoid tumors. These are the conditions which are included under ACTH dependent endogenous cause of Cushing syndrome. Next is about ACTH independent cause. Here, the adrenal gland is secreting the steroids without the influence of ACTH. This is because a problem is in the adrenal gland itself. So it is associated with adrenal pathology. The usual pathology is in the form of tumors in the adrenal gland, which includes condition like carcinoma or adenoma. So these conditions come under ACTH independent causes. But please remember, the overall most common cause of Cushing syndrome is exogenous administration of steroid. This is the overall most common cause, which should be remembered. Now, moving on to clinical features of Cushing syndrome. Please remember, even though we have studied so many characteristic external appearances of a patient with Cushing syndrome, as far as pediatric population is concerned, you should remember the common sign of Cushing syndrome is growth retardation, or the usual feature is growth retardation. Which is characterized by decreased growth velocity, thereby resulting in short stature. This is the overall common manifestation of Cushing syndrome in children. The other features which we all know about is the moon facies or the buffalo hump appearance, which is due to fullness of the cheeks giving rise to the moon facies appearance, and the face appears fully rounded like a moon. Second is deposition of excess fat in the neck region, backside of the neck gives rise to the buffalo hump appearance. They also have obesity, which is usually an abdominal obesity or a truncal obesity, and the common reason which is attributed to moon facies, buffalo hump and obesity is due to abnormal distribution of fat which occurs under the influence of excess glucocorticoid. Another characteristic feature is the presence of abdominal striae. This is due to distension of the abdomen associated with obesity, causing appearance of abdominal striae, and the classical description is purplish striae. It refers to the color of the striae noted in the abdomen of children with Cushing syndrome. You can look at this picture which describes the classical findings of Cushing syndrome. Can you notice the moon facies in the first picture? Second picture also describes the characteristic moon facies. You can see the fullness of the cheeks. And another important finding you can see in the last picture is the purplish abdominal striae, which are classical findings in case of Cushing syndrome. The other additional findings would include hypertension, increased blood pressure. Why? Because glucocorticoids also have some intrinsic mineralocorticoid activity. So when they become in excess, they will also act on the mineralocorticoid receptor, thereby resulting in hypertension. Now, in cases of ACTH dependent Cushing syndrome, there is also hirsutism which is noted. What is the reason? ACTH will cause stimulation of the adrenal gland in general. So what happens? Under the influence of ACTH, the adrenal glands start producing a lot of steroids, including the gonadal steroids, which includes the androgens like testosterone. Excess of testosterone is associated with a form of virilization in the females, which is manifesting as hirsutism in females. Okay, and please remember, these children generally have delayed puberty. And another characteristic feature is the presence of muscle weakness. Okay. And which group of muscles are affected in Cushing syndrome? This is a commonly asked exam question. It is a proximal group of muscle. Proximal group of muscles. Okay, right. So something like shoulder muscles or in the lower limb, thigh muscles are commonly affected. That is what we call proximal muscle weakness associated with Cushing syndrome. These are the characteristic features of Cushing syndrome. Please don't forget the fact that growth retardation is overall the common feature. Moving on to investigations in case of Cushing syndrome. The initial test is the screening test, where we have to find evidence of increased steroid in the body. This can be done by two important testings. One is 24-hour urine free cortisol measurement, which will show increased levels of urinary cortisol. Second is overnight dexamethasone suppression testing, which includes administration of overnight single dose of dexamethasone in the dose of 0.3 milligram per meter square. It is administered as an overnight single dose. Now, the next day morning, we check for the levels of cortisol. However, because of excess cortisol, this dexamethasone is not able to suppress that cortisol. So what happens? If you measure cortisol level, it will be increased in cases of Cushing syndrome. These are the screening tests in Cushing syndrome. How do you confirm your diagnosis? It is by a testing called as low dose dexamethasone suppression test. Please carefully note the words. For screening, it is overnight dexamethasone suppression. For diagnosis, it is low dose dexamethasone suppression. So how much is the dosing? We give 5 microgram per kilogram of dexamethasone every 6 hours for 2 days. And after that, we estimate the levels of cortisol. Even after giving many doses of dexamethasone also, the cortisol level will not be suppressed in case of Cushing syndrome. So in dexamethasone suppression testing also, you will get high levels of cortisol, and that is going to confirm the diagnosis of Cushing syndrome. Once you have confirmed the diagnosis of Cushing syndrome, the next step is to look for whether it's a ACTH dependent Cushing syndrome or it's a ACTH independent Cushing syndrome. For that, you have to measure the levels of serum ACTH. Okay. If serum ACTH is low value is defined by a value less than 5 picograms per ml, then it is a ACTH dependent condition. What is that source? Usually it's a adrenal source. Like for example, an adrenal tumor like carcinoma or adenoma. The other result you can get is high levels of ACTH. High level is defined by a value more than 15 picograms per ml. High level means what? It is an ACTH dependent condition. What are the two usual ACTH dependent conditions we know? One is pituitary adenoma. Another one is a ectopic ACTH secreting tumor. Now, how to differentiate between these two conditions? You look at the value of ACTH. In ectopic ACTH, you will have very high levels. Very high levels are defined by values more than 100 picogram per ml. Okay? And another way by which we can differentiate whether it's an ectopic or a pituitary source is giving a high dose of dexamethasone. This is called high dose dexamethasone suppression testing. So what are we basically looking for here? We see whether the levels of ACTH is suppressed after giving high dose of dexamethasone. If the ACTH levels are suppressed, it is suggestive of pituitary adenoma. Okay, so if there is suppression of ACTH following high dose dexamethasone, it is pituitary adenoma. If there is no suppression of ACTH, that means ACTH level still remain high even after giving high dose dexamethasone, then it is suggestive of ectopic ACTH secretion. This is how we algorithmically diagnose what could be the reason of Cushing syndrome in a given child with features of Cushing syndrome. Now, the treatment of Cushing syndrome depends upon the cause of Cushing syndrome. For example, if you identify a tumor, it may be a pituitary tumor or an adrenal tumor which is associated with Cushing syndrome, the obvious treatment option is surgical removal of the tumor. Okay. Now, in cases of adrenal conditions associated with Cushing syndrome, you can also try something called medical treatment. Okay. What is the role of medical treatment? You give some drugs to completely suppress the adrenal gland. Or in other words, this treatment is also called as medical adrenalectomy. The commonly used drugs for this purpose include ketoconazole, metyrapone, and metotane. So these are the drugs which can completely suppress the adrenal gland and result in medical adrenalectomy. So this is about the treatment of Cushing syndrome. Next, we are going to discuss about a disorder characterized by decreased functioning of the adrenal gland called as adrenal insufficiency. The usual etiology is a primary adrenal insufficiency. What is the meaning? It is a problem in the adrenal gland itself. You call it as primary adrenal insufficiency. To differentiate, secondary adrenal insufficiency refers to a problem in the brain wherein the pituitary gland is not producing adequate ACTH for the adrenal gland to function. So primary means a problem in the adrenal gland, whereas secondary means a problem in the CNS or the brain. Okay, now let us see what are the common causes of primary adrenal insufficiency. In the present scenario, the most common cause is autoimmune destruction of the adrenal gland, and this goes by the name of a very famous condition. What we all know, it is Addison's disease. At this point, I want you to remember that this Addison disease can occur either as an isolated entity or it could occur as a part of APS. What is APS? It is autoimmune polyendocrine syndrome. You can infer from the name itself that in this condition you will have autoimmune problem not only involving a single endocrine gland but multiple glands. There are many varieties of autoimmune polyendocrine syndromes, but Addison disease is usually associated with APS1 and APS2. In APS1, the characteristic features are AD. AD refers to Addison's disease along with chronic candidiasis along with hypoparathyroidism. This is APS1. APS2 is characterized by, again, Addison disease plus either autoimmune thyroid problem like Hashimoto's thyroiditis and or type 1 diabetes mellitus. This is what is called APS2. I just want you to remember the fact that Addison disease can either occur isolated or as a part of polyendocrine syndromes. The other common causes of primary adrenal insufficiency includes infections. This includes infections like HIV, tuberculosis, or acute meningococcal infection, or what we call acute meningococcemia. In acute meningococcemia, what happens is that there is a sudden adrenal hemorrhage. And this condition is also called as Waterhouse-Friderichsen syndrome. It could also occur as a part of metabolic disorders like adrenoleukodystrophy and some cases of congenital adrenal hyperplasia. The typical example is 21-hydroxylase deficiency. These are the usual conditions which are associated with primary adrenal insufficiency. As I said before, secondary refers to some problems in the CNS, especially the pituitary. It could be something like a tumor or trauma associated with the pituitary, causing decreased production of ACTH, thereby decreased stimulation of adrenal gland and decreased production of adrenal hormones. That is what is called secondary adrenal insufficiency. Generally remember, primary adrenal insufficiency is far more common compared to secondary adrenal insufficiency. Now moving on to the features of adrenal insufficiency. It depends on whether it's an acute presentation or a chronic presentation. Acute presentation usually is associated with infections like meningococci, the classical Waterhouse-Friderichsen syndrome, which usually has a sudden or acute presentation. Whereas chronic presentation is usually associated with autoimmune presentation like Addison disease. Now, if there is an acute presentation, the classical features include sudden decrease in glucocorticoid as well as mineralocorticoid, correct? So this condition clinically presents as shock. We know that shock is associated with many conditions, but in this particular condition, how much ever fluid you give to this patient, the patient does not seem to improve. That is what is characteristic of adrenal insufficiency associated shock. Or in other words, we can also remember as fluid unresponsive shock. That is a key word for shock associated with adrenal insufficiency. Okay. And because of decreased levels of aldosterone, which is a mineralocorticoid, what electrolyte abnormalities can occur? The patient can have losing of sodium and increased retention of potassium. So they can have hyponatremia as well as hyperkalemia. What is the reason? It is due to deficiency of aldosterone. Okay. Now please remember, when a patient presents in an acute stage, obviously fluid has to be given in the treatment. IV fluids has to be given. As I said before, only fluid will not be sufficient. You have to give injection hydrocortisone. Only after administering injection hydrocortisone, you will see any sort of improvement in this patient with shock. That is about acute adrenal insufficiency. Moving on to chronic adrenal insufficiency, here the patient over a period of time presents with features like hypoglycemia and letharginess, this is attributed to low levels of glucocorticoids. And due to low levels of mineralocorticoids, they will have postural hypotension, as well as salt craving. And this is due to decreased levels of mineralocorticoid like aldosterone. Please remember, aldosterone results in sodium loss, thereby the patient develops a craving for salt or sodium. This is the reason for features encountered in a chronic type of adrenal insufficiency. Remember, in chronic cases, the symptoms may look little vague and you cannot point to a diagnosis. So in all chronic cases of adrenal insufficiency, you are supposed to do a testing. And the usual test which we do is ACTH stimulation testing. What we do, we give injection of ACTH to the patient. Then after 60 minutes or 1 hour, you will check for the level of cortisol. Obviously, what will happen to the level of cortisol in adrenal insufficiency? It will be decreased. So you will have low cortisol levels. Low cortisol is defined by a value less than 18 micrograms per deciliter. This is what is called low level of cortisol, which is diagnostic of adrenal insufficiency. Okay, now if you have diagnosed a case of chronic adrenal insufficiency, obviously the treatment is replacement of deficient hormones. You have deficiency of glucocorticoid as well as mineralocorticoid. So glucocorticoid generally replaced in the form of hydrocortisone, and mineralocorticoid is replaced in the form of fludrocortisone. So hydrocortisone plus fludrocortisone would be the management in these patients. And remember, if it is going to be an autoimmune disorder, you have to give a lifelong treatment with hydrocortisone and fludrocortisone. Okay. Now, you should all know that the level of steroid requirements in the body is going to increase at the time of stress. So for these patients also, at the time of stress, you need to give increased doses of these steroids. Okay, how much increase in the dose? It is increase of 2 to 3 times in case of a minor stress, like an infection, and increase of 4 to 5 times in case of a major stress, like for example surgery or a life-threatening infection. Conditions like that, you require very high doses of steroids. So please remember, the principle is simple: lifelong replacement of steroids with increase in dose at the times of stress. That is about the discussion of adrenal insufficiency. Next discussion is about a group of disorders called congenital adrenal hyperplasia. Let us try to understand what is this condition in an outline, and then I will discuss elaborately. This is a autosomal recessive disorder, okay, characterized by deficiency of enzymes in adrenal biosynthesis of hormones. The common enzyme deficiencies encountered include: the most common is 21-hydroxylase. I can write it as 21-OH. This is the most common enzyme deficiency. The second commonest enzyme deficiency is 11-hydroxylase. The third important is 17-hydroxylase. And the fourth one is 3-beta-HSD, that is 3-beta-hydroxy steroid D for dehydrogenase. These are the 4 important enzyme deficiencies which can be encountered in congenital adrenal hyperplasia. Okay, let's imagine what is going to happen. Whenever these enzymes are deficient, it would result in decreased synthesis of the hormones from the adrenal gland. So what happens whenever there is a low level of adrenal hormones in the body, especially glucocorticoid, it would cause a feedback stimulation of pituitary adrenal axis. So what is going to happen? The pituitary is going to respond by increasing the levels of ACTH, or increase release of ACTH from the pituitary occurs. And this ACTH will go to the adrenal gland and cause stimulation of the adrenal gland. This is the basic pathophysiology which happens in congenital adrenal hyperplasia. You can notice in this condition there is increased levels of ACTH, right? If you look at the expansion of the name ACTH, adrenocortico, T for trophic hormone. Trophic is something which refers to the growth. Okay, now this increased ACTH will cause increased growth of the adrenal gland. That is why you can very easily infer the name as congenital adrenal hyperplasia. What is this hyperplasia due to? It is due to increased levels of ACTH. That's what you should remember. That's how the name of congenital adrenal hyperplasia is derived. Now, let us look in detail about the different enzyme deficiencies: 21, 11, 17 and 3-beta-hydroxysteroid dehydrogenase deficiencies. Starting with the discussion of most common enzyme deficiency, that is 21-hydroxylase deficiency. This is a picture depicting the detailed steps of adrenal gland biosynthesis of steroids. You can see the starting point is the cholesterol and the final Hormones which are produced are aldosterone, cortisol, and testosterone. Okay, these are the main adrenal steroids which are produced. Now let us start our discussion of 21 hydroxylase deficiency. What is going to happen? Here is the 21 hydroxylase. When it is going to be deficient, what is going to happen? The steps below that deficient enzyme will not occur. So these steps will not occur. So obviously you can notice that there will be decreased levels of aldosterone, decreased levels of cortisol. There is no 21 hydroxylase in the third step. You can very easily notice that. So what will happen? That third step alone will go on occurring without any interruption. So that would result in increased levels of testosterone. Okay, so this gives rise to the manifestation which you can notice in case of 21 hydroxylase deficiencies, starting with low levels of aldosterone. You all know that aldosterone is needed for the regulation of blood pressure in the body. So this would result in decrease in the blood pressure. And what are the electrolyte imbalances? It is hyponatremia. Along with that, you have hyperkalemia. Because of hyponatremia, this is also called as a salt wasting type. Salt wasting type of CAH. Okay, right. Some of these children can have very low levels of blood pressure that it can result in hypotensive shock as well. Okay. The next set of feature is related to low levels of cortisol. What is going to happen? Because of low cortisol, they can have hypoglycemia. Okay. And they are also having increased levels of testosterone. This creates a problem in a female baby. How? Because under the influence of testosterone, the external genitalia undergoes virilization. So in a female baby, the genitalia may look like a male instead of a female. So what do you call this? This is called ambiguous genitalia. Ambiguous genitalia. Whereas in a male, the genitalia would look normal only because testosterone is definitely needed. However, very high levels of testosterone would predispose to the development of early puberty or precocious puberty. Okay, right. And as I said before, there is also increased levels of ACTH. Why? Because of the feedback, the pituitary starts releasing more ACTH. So as I said before, there will be increased levels of ACTH. And this is going to result in hyperpigmentation. What is the reason for this? It is because ACTH has got a similarity to MSH or melanocyte stimulating hormone. So high levels of ACTH would also result in increased production of melanin, which is contributing to hyperpigmentation in these cases. So these are the classical features of 21 hydroxylase deficiency. This picture depicts the ambiguous genitalia in a female child due to 21 hydroxylase deficiency. What could be the treatment of this condition? Remember, we have to replace what is deficient. Here, aldosterone, mineralocorticoid, and cortisol, glucocorticoid are deficient. So same principle, you have to give lifelong replacement of hydrocortisone and fludrocortisone. Again, as I discussed before, during the time of stress, the dose of the steroids has to be increased. Now, an important point in the management is the female children are having ambiguous genitalia. So for them, you need to do corrective surgery. For example, in female children, the clitoris can be unusually enlarged. So you have to do clitoroplasty. And the usual timing at which clitoroplasty is done is between 2 to 6 months of age. Okay, right. Now, as I said before, 21 hydroxylase is the most common congenital adrenal hyperplasia. So in many cases, there is also a newborn screening test being performed to detect this condition early. And for you to know what is the test being done in newborn screening, let's go back to the algorithm. What is that metabolite which is before 21 hydroxylase? Can you notice this metabolite? 17 hydroxyprogesterone. What will happen? The deficiency is at the level of 21 hydroxylase. So the metabolites and enzyme below the 21 hydroxylase will not be produced. However, before 21 hydroxylase, every step is going to occur, as a result of which there will be increased levels of 17 hydroxyprogesterone. And this is the newborn screening test which we do. So what is that screening test? Estimating the levels of 17 OHP. OHP here refers to 17 hydroxyprogesterone. That level will be elevated, and that is the screening test which we do in congenital adrenal hyperplasia due to 21 hydroxylase deficiency. This is a commonly asked exam question which you should know about. That is about all the features of 21 hydroxylase deficiency. Now let us look at the salient features of other enzyme deficiencies as well. The next enzyme deficiency is 11 hydroxylase deficiency. Where is that 11 hydroxylase? You can see here is it. It is 11 beta hydroxylase. Let's imagine that this enzyme is deficient. So what will happen? Again, this step will not occur, resulting in low aldosterone. Cortisol will not be produced, low cortisol. But you can very well notice that there is no 11 beta hydroxylase in the third step. So what will happen? The levels of testosterone will be again increased in this condition. Okay. So what are the features you are going to expect? One is due to testosterone increase. What would be the features? You automatically know from our previous discussion. What is it? It is going to cause ambiguous genitalia in a female due to virilization by testosterone, and in a male it will cause precocious puberty. What is the other finding? Aldosterone level is low. Okay, so you are expecting low blood pressure, but it does not happen that way. Why? Because you look at that algorithm again. Before 11 beta hydroxylase, what is that metabolite which is produced? It is 11 deoxycorticosterone. Remember this point. Levels of 11 deoxycorticosterone obviously would be elevated in this condition, and 11 deoxycorticosterone has got mineralocorticoid effect. So what will actually happen in this condition? There will be excess mineralocorticoid activity due to the influence of 11 deoxycorticosterone. So actually the blood pressure is increased in this condition. Okay, so this is an important point to note. In this condition, aldosterone level is low, but still blood pressure will be increased. Okay, the other feature is the common one. What is that? Cortisol is low. So low cortisol will result in hypoglycemia. And as I said before, in all cases of congenital adrenal hyperplasia, you will have increased ACTH. And what would be the feature of that? You get hyperpigmentation. These are the classical features of 11 hydroxylase deficiency. Next, moving on to 17 hydroxylase deficiency. Where is that 17 hydroxylase in the algorithm? You can see it here. Okay. So imagine that this enzyme of 17 alpha hydroxylase is going to be deficient. So what will happen? It will not occur beyond this step. So all these steps will be affected. Okay. Thereby resulting in low level of cortisol, low level of testosterone as well. But what will happen to the level of aldosterone? No way there is 17 alpha hydroxylase in that step. So aldosterone level will be increased. So what will happen? The first feature would be increased levels of aldosterone. What is going to happen? Because of increased aldosterone, the blood pressure increases. You will have increased sodium retention causing hypernatremia. You will also have hypokalemia. The next is, you can notice very clearly here, there is low levels of testosterone. Okay. What is the problem because of this? Here, the males are going to be more affected because of low testosterone. So what happens? It results in decreased virilization or under virilization. So what are the features you can get? A male genitalia would not appear like a typical male genitalia. You can get some problems like hypospadias, bifid scrotum. All this is due to under-virilization due to low testosterone. Even these children can also have cryptorchidism. Okay, and in severe cases of testosterone deficiency, the genitalia may not even look like a male at all. So what is that? Yes, again it is ambiguous genitalia in a male. Okay, so these are the features of low testosterone in a male. What would be the problems in a female? In a female, the genitalia definitely appears to be normal. Another feature to be noted is, at the time of puberty, they have a delay in the development of sexual characteristics, secondary sexual characteristics. Okay, these are the features noted in a female. And another feature is a very common feature. What is that? There will be increased levels of ACTH, which would result in hyperpigmentation. Okay, so these are the classical features of 17-hydroxylase deficiency. Moving on to the last enzyme deficiency, which is 3-beta-HSD deficiency. Where is the 3-beta-HSD? Now remember 3 for 3. What is that? It is common to all the three pathways. Can you notice that? Here is 3-beta-HSD, that is hydroxysteroid dehydrogenase. Here also there is 3-beta-HSD, and in the third pathway also there is 3-beta-HSD. So what is going to happen? In this condition, all the pathways are going to be affected. So below that enzyme, okay, none of the steps are going to occur. Okay, so there will be low aldosterone, low levels of cortisol, as well as low levels of testosterone. Okay, so you know the common features of low blood pressure, hypoglycemia due to low levels of cortisol, and increased ACTH causing hyperpigmentation. In this particular condition, there is a peculiar observation. What is that? You see this metabolite. What is that? Dehydroepiandrosterone, which can be abbreviated as DHEA. What is going to happen? There will be increased levels of dehydroepiandrosterone. Okay, this is a weak androgen. Remember this point. Because of weak androgen, it can cause some amount of virilization. Some virilization in females. Remember, it won't be causing a severe manifestation like ambiguous genitalia and all, but mild degrees of virilization in the form of hirsutism, acne, or menstrual irregularity in females. Whereas in males, it is associated with under-virilization. Under-virilization. The reason is because this DHEA has got only a weak androgenic effect. So the features of under-virilization, like the same features I discussed before, like hypospadias, bifid scrotum, even cryptorchidism, can also be associated in case of males. So the presence of increased DHEA is a very peculiar feature which we always remember for 3-beta-HSD. Okay, so that is about the discussion of the common enzyme deficiencies in congenital adrenal hyperplasia. Now, I am going to tell you about the simplified approach to congenital adrenal hyperplasia, like a summary of what we have studied till now. This will be very helpful for you when you solve the clinical scenario questions in CAH. The first thing to look for in a clinical case scenario related to CAH is look for features of salt wasting. Look whether the question is mentioning like low blood pressure, shock, hyponatremia. If it is yes, what are the usual disorders which are associated with salt wasting? It is 21 hydroxylase deficiency, and another one is 3 beta hydroxysteroid deficiency. Okay. If there is no salt wasting, then the other two varieties, namely 11 hydroxylase deficiency and 17 hydroxylase deficiency. So by this approach itself, you will be able to rule out two options given in the question. Now we have to know how to differentiate the two conditions which are remaining. Next part in solving this question is to look for the genitalia changes, if at all given in the question. How can we divide it? We can divide it into conditions associated with increased levels of testosterone or decreased levels of testosterone. Please note that they will not directly give you increased and decreased testosterone. It will be like this. Increased testosterone, the manifestation would be given as precocious puberty in a male or ambiguous genitalia in a female. Decreased testosterone will be given as a normal genitalia in a female baby, whereas it is under virilized genitalia in a male baby. Rarely, it can also be associated with ambiguous genitalia in a male baby in case of decreased testosterone. So let us look at what are all the conditions. Increased testosterone is present in 11 hydroxylase deficiency and 21 hydroxylase deficiency. So both these conditions, you will have precocious puberty in male as well as ambiguous genitalia in females. Decreased testosterone. What is the other condition? 17 hydroxylase deficiency. So in this condition, what you will be having? You will have normal genitalia in a female, whereas under virilized genitalia in a male baby. Please remember, if it is very severe, decreased testosterone can even be associated with ambiguous genitalia in a male baby also. Now, very important, remember 3 beta HSD is not generally associated with ambiguous genitalias. Why? Because in 3 beta HSD, you have increased DHEA. Can you remember the last part of our discussion? I told you this DHEA has got a mild androgenic effect. So what happened? It will cause some sort of virilization in a female and under virilization in a male. That is a speciality of 3 beta HSD, which I have discussed previously. So this will summarize the features of congenital adrenal hyperplasia, and please look only at this point whenever you are solving a clinical scenario question, and that will help you to easily pick up the answer for that question from a given clinical scenario. That ends our discussion of adrenal disorders in children.